Welcome to the debate. Today we are confronting a clinical scenario that strikes absolute fear into the heart of every emergency physician, pediatrician, and parent, the acute scrotum. We're analyzing the high-stakes collision between two diagnoses that look identical on the surface but require radically different management: testicular torsion and epididymitis.
It really is a diagnostic dilemma that perfectly encapsulates that tension in medicine, the need for speed versus, the need for accuracy. We are wrestling with a central question about risk management today. When a young male presents with severe pain, but the symptoms are ambiguous, maybe he has burning during urination, or the exam isn't quite textbook. Do we rely on the heuristic of operate immediately, or do we trust the nuance of modern diagnostics like ultrasound to save a child from an unnecessary surgical exploration?
I'm going to take a very hard line on this today. I'm taking the position of aggressive intervention. My argument is that in this specific pathology, time is the only metric that matters. The 6-hour window is absolute. I'll argue that misleading symptoms must be ignored, the distractions have to be pushed aside, and the bias must always, without exception, lean toward the operating room to save the organ.
And I'll be taking the position of diagnostic precision. I'll argue that because conditions like epididymitis mimic torsion so closely, rushing without understanding the physiological overlaps or utilizing the imaging data we have at our disposal, well, it often leads to poor decision-making. We're essentially debating whether we treat the patient based on a protocol of fear or based on the evidence right in front of us.
Let's establish the stakes immediately, because they are incredibly high. My position is anchored in the 6-hour rule. The literature on testicular salvage rates is, well, it's unforgiving. If we detorse, that is, if we get into the OR and untwist the cord within 6 hours of symptom onset, the salvage rate is between 90 and 100%. It's effectively a cure. You save the testicle, you save the function.
Those are the numbers we all learn in medical school, and they are compelling, yes.
But look at the cliff we fall off immediately after that window closes. Between 6 and 12 hours, that success rate drops to 50%. It becomes a coin flip. After 24 hours, you are looking at less than 5%. The organ is essentially gone. This is why I argue that 6 equals save. Sudden pain plus ischemia, a lack of blood flow, equals a 6-hour countdown. My stance is that any delay for diagnostic certainty, whether it's waiting for a urine sample or debating the nature of the pain, is a failure of management. If there is sudden severe pain and an absent cremasteric reflex, you cut. You do not wait.
That is the classic surgical dogma, and I respect the urgency because the outcome of a miss is it's terrible. However, my position is that this cut first, ask questions later mentality ignores the reality of the differential diagnosis. We have to talk about epididymitis. This is an inflammation of the coiled tube at the back of the testicle, and it is a major mimic. It presents with severe pain, swelling, and redness. But the treatment is antibiotics and supportive care, not a scalpel.
But the cost of missing torsion is permanent loss. The cost of operating on epididymitis is a negative exploration. One is a tragedy, the other is an inconvenience.
I think calling surgery an inconvenience is a bit reductive. A negative exploration involves general anesthesia, surgical risks, recovery time, psychological trauma for the child, and, significant financial cost. If we operate on every boy with groin pain because we're afraid to diagnose, we are doing harm. My argument is that we have tools, specifically Doppler ultrasound, that can distinguish the enlarged hypervascular epididymis from the ischemic, twisted cord of torsion. Rushing to surgery without acknowledging the limitations of the physical exam is not aggressive medicine, it's imprecise medicine. We have to understand why the symptoms overlap before we decide to cut.
I think that relies too heavily on a perfect clinical environment, which rarely exists in the middle of the night. But let's move into the core debate. I want to attack the first major point of contention you raised: the symptoms themselves, specifically urinary symptoms. This is the biggest trap for the clinician.
It's a logical trap, though. We're talking about dysuria, painful urination, and frequency, the need to go to the bathroom constantly. These are textbook hallmark signs of a urinary tract infection or sexually transmitted epididymitis.
If a 15-year-old tells me it burns when I pee, my reasonable clinical judgment suggests I should pivot away from torsion. You don't twist a spermatic cord and suddenly get a bacterial bladder infection.
That is a dangerous assumption because it relies on a surface-level understanding of anatomy. The source material is very specific here. We have to look at the neuroanatomy to understand why the patient is saying that. The testicle and the urinary tract, specifically the bladder and urethra, they share sensory nerve pathways. They map to the same spinal segments, T10 to L2.
We know the dermatomes overlap. Yes, that's standard physiology.
But think about the practical implication of that overlap in a moment of crisis. When the spermatic cord twists, the pain signals are violent. They are screaming through those nerve pathways. The brain, which is trying to interpret this massive influx of data, gets confused. It misinterprets the source location. It reads that signal as bladder discomfort. So the patient feels a genuine sensation of, I need to pee or it hurts to pee, but there's no bacteria. It's referred sensation. It's a neurological trick.
I concede the neuroanatomy is valid. Referred pain is real. We see it in heart attacks presenting as arm pain. However, I think you're dismissing the predictive value of the symptom too easily. While the T10 to L2 overlap explains the sensation, we have to look at the whole picture. Epididymitis involves inflammation of the structure physically touching the testis. In sexually active teens, this is often caused by chlamydia or gonorrhea, which causes real urethritis, real inflammation.
But consider the workflow. If you assume dysuria means infection, you order a urinalysis. You wait 45 minutes for the kid to produce a sample because he's in pain. You wait another hour for the lab to run it. Meanwhile, the testicle is dying.
But the onset is the differentiator. This is where the history taking is critical. Torsion is sudden. It is a lightning strike. It wakes the patient from sleep. Epididymitis is gradual. It creeps up over hours or days. If a patient has dysuria but the pain hit him like a hammer, I agree with you, ignore the bladder symptoms. But if the pain has been building for 2 days and he has dysuria, that is a mimic. That is likely infection.
Gradual is a deeply subjective term. Patients, especially terrified teenagers, are notoriously poor historians. A boy might say it started gradually because he felt a twinge 4 hours ago, but the actual torsion event happened 30 minutes ago. Furthermore, the source material notes that severe testicular pain causes autonomic reflexes, actual bladder spasms. The kid is vomiting from the pain. His bladder is physically spasming, and he feels urgency. It looks exactly like a UTI.
But there is a distinct difference in the lab data, though. In torsion, the urinalysis is almost always clean. In epididymitis, we see pyuria, white blood cells in the urine.
And my point is that waiting for that clean urinalysis consumes the window of salvage. If you see UTI symptoms in an acute scrotum, you should think torsion mimicking infection, not the other way around. The clean urine only confirms what you should have already suspected from the pain levels.
I think we have to agree to disagree on the speed of the lab workup versus the value of the data. But this brings us to the physical exam. If the history is muddy, if the patient is vague about the timing, you argue the exam should be the deciding factor.
I do. We need to talk about the bell clapper deformity. This is the anatomical root cause of the entire crisis, and understanding it explains why the exam findings are what they are.
The congenital anomaly.
Exactly. Normally, the testicle is anchored to the scrotal wall firmly. It can't spin. But in some males, that attachment is missing or attaches too high up on the cord. The testis hangs horizontally, like the clapper inside a bell. It is free to rotate within the tunica vaginalis. When that bell clapper swings and twists the cord, the physical signs are usually screaming at you.
In a textbook case, sure, you see the high-riding testis because the cord has physically shortened as it twisted, pulling the organ up. You see the horizontal lie.
And you see the absence of the cremastomeric reflex. For me, this is the gold standard of the physical exam. The cremaster muscle is a thin layer of muscle covering the testis. Physiologically, if you stroke the inner thigh, that muscle should contract and pull the testicle up. It's a protective reflex. In torsion, because of the ischemia and the twisting, that reflex is paralyzed. It's absent. If a boy has sudden pain and you scratch the thigh and nothing happens, that is a surgical emergency.
It is a massive red flag.
Absolutely. But calling it a gold standard ignores the messiness of the real world. Let's look at the physiology again. Adolescents generally have a much stronger cremastomeric reflex than adults. Their muscles are active and reactive.
Which implies that if it's absent, it's even more significant. If it should be strong and it's gone, that tells you something is profoundly wrong.
Or it implies that it's easily manipulated by other factors. Sudden contractions from cold water, cold air in the exam room, or even extreme anxiety can trigger the muscle to pull the testis up and hold it there. A retracted testis in a freezing ER bay might look high-riding. It might look like the reflex is absent because the muscle is already fully contracted in spasm.
You're describing edge cases to justify hesitation.
I'm describing common presentations. Conversely, consider early torsion. Before significant edema, swelling sets in, the lie might not be fully horizontal yet. Relying solely on the exam to rush to surgery bypasses the nuance. The exam overlaps. Viral orchitis, infection of the testicle itself, can cause swelling that mimics the high-riding position.
I think relying on nuance here is dangerous. You mentioned active muscles. That's actually a key point for my side. Torsion often happens during sleep or exercise. Why? Because of that strong cremasteric reflex you mentioned. The rapid growth of the testes during puberty makes it heavier, more prone to swinging on the cord. If a kid wakes up from sleep with pain, that is torsion. That is the bell clapper swinging in the night. If we waste time debating if it's just a cold room, we lose the window.
This leads us inevitably to the technology debate. If the history is confusing, gradual onset but severe pain, and the exam is equivocal, maybe the reflex is hard to elicit, we have to talk about ultrasound.
A dangerous luxury. That is what ultrasound is in the acute window.
That's a strong accusation for a non-invasive diagnostic tool that gives us real-time hemodynamic data.
It is dangerous because of the clock. If you are at a rigorous academic center, maybe you get an ultrasound in 20 minutes. If you are at a community hospital, calling in the tech takes an hour. Reading it takes another 20. If the patient has been in pain for 4 hours, that delay pushes them right out of the salvage window.
But let's look at what the ultrasound actually tells us. It's the only way to visualize the pathology without cutting. It provides the whirlpool sign. You can literally see the spermatic cord twisted like a spiral staircase. But more importantly, it shows Doppler flow.
Explain the Doppler concept for the listener who isn't a radiologist, because this is where the interpretation gets tricky.
Right. Doppler ultrasound visualizes the movement of blood relative to the probe. It uses color to show direction and velocity. In epididymitis, the tissue is inflamed. Inflammation means the body sends more blood to the area to fight the infection. So on the screen, the epididymitis lights up like a Christmas tree. It's hypervascular. In torsion, the cord is choked. The testis is dark. It's ischemic. It distinguishes the two pathologies with high specificity. Why would you cut a child open when a 10-minute scan could prove he just needs antibiotics for a hot epididymitis?
Because the scan can lie. And I don't say that lightly. The source material is explicit. Normal blood flow on an ultrasound does not fully exclude torsion.
That is true in cases of intermittent torsion or very early presentation. I grant you that.
Granting that is granting a massive blind spot. You can have intermittent torsion where the cord twists and untwists. The flow might look preserved at the exact moment the probe is on the skin, but the anatomical defect is still there. Or consider early torsion. The venous outflow, the blood leaving the testicle, gets blocked first because veins are soft and compressible. The arteries, which are thicker and have higher pressure, might still be pumping blood in.
So you have inflow but no outflow. Severe congestion.
Exactly. And the Doppler might show arterial flow present. A clinician sees normal flow on the report and sends the kid home. That is a catastrophic miss. If the clinical picture suggests torsion, sudden pain, absent reflex, you do not need the scan. You need the OR. The ultrasound is only as good as the moment it is taken.
That's a compelling argument for the early window. I agree that if the timeline is tight, say 3 or 4 hours in, and the suspicion is high, you skip the scan. But many patients present in the gray zone. Maybe the pain is moderate. Maybe the reflex is equivocal. In those cases, the ultrasound is essential.
It prevents us from operating on every case of epididymitis or torsion of the appendix testis, a harmless twisting of a tiny vestigial structure that requires no surgery at all.
I will concede that if the presentation is truly ambiguous and the pain has been present for a long time, ultrasound has a role. But my fear is that clinicians use it as a crutch. They order it because they're afraid to commit to the diagnosis, not because they need the information. And that hesitation kills testicles.
Let's talk about that long-time scenario, the late presentation. We focused heavily on the first 6 hours, but what about the boy who comes in at hour 10 or hour 25?
The strategy remains the same. You operate. But looking at the data, salvage rates drop to 10 to 20% between 12 and 24 hours. After 24 hours, it is less than 5%. The organ is likely infarcted. It's necrotic tissue. Is emergency surgery really mandated when the probability of saving the organ is effectively zero?
Absolutely. You never time out of exploration. There are 3 critical reasons for this, and they are non-negotiable. First, biology is variable. Some testes survive longer than expected due to partial torsion. Maybe it only twisted 180 degrees instead of 720, or due to collateral blood flow. We've seen salvageable tissue well past the 24-hour mark in rare cases. You don't know until you look.
That is fair, though rare.
Second is pain control. A necrotic, dying testicle releases inflammatory cytokines. It is incredibly painful. Removing it or detorsing it resolves that suffering immediately. But the third reason is the most important. The contralateral testicle.
The healthy one.
Correct. The bell clapper deformity is almost always bilateral. If the left side twisted because it wasn't fixed to the wall properly, the right side is likely floating in the breeze too, waiting to twist next week or next year. We aren't just operating to manage the dead testicle. We are operating to perform an orchiopexy on the healthy one.
Orchiopexy being the procedure to physically stitch the testis to the scrotal wall.
Exactly. Fixing it in place so this never happens again. If you don't operate, you risk leaving that boy with 0 functional testicles in the future. You are saving his fertility and his hormonal function, just not via the organ that is currently hurting.
I accept the necessity of contralateral fixation. That is a critical point regarding long-term fertility and hormonal health. However, I would argue that the urgency changes. If we are past the 24-hour mark, the emergency is preventing future harm, not salvaging the current organ. The mindset shifts from race against the clock to damage control.
But functionally, for the surgeon and the ER doc, the order is the same. Consult urology, go to the OR. Whether it's to save the dying organ or protect the living one, the intervention is surgical.
True, but the counseling to the family is very different. In the first 6 hours, we're offering hope of salvage. At 24 hours, we're managing expectations of loss. That distinction matters for the patient experience. It prepares the parents for the likelihood of an orchiectomy, removal of the testicle, rather than a save.
It matters emotionally, yes, but clinically, the algorithm holds. Sudden, severe scrotal pain is a surgical event until proven otherwise.
I think we're reaching a point of synthesis here. I want to summarize my view on the mimics. While I understand your aggressive stance, I maintain that the astute clinician must recognize that urinary symptoms are often neurological tricks. Recognizing that dysuria is referred pain prevents us from going down the rabbit hole of treating a phantom UTI. But recognizing the limitations of the exam, knowing that cold weather or anxiety can mimic torsion signs, keeps us humble. We use ultrasound not to delay, but to confirm when the picture is blurry.
And I will reverse that perspective. Recognizing the mimics is only useful if it reinforces the decision to operate. If you understand that dysuria is a neurological trick, you won't be fooled into ordering a urinalysis and waiting. You will see the UTI symptom and think torsion. I reassert the mnemonic, 6 equals save. Sudden pain, ischemia, 6-hour window.
We can agree that time is testicle.
We certainly can. And while ultrasound and urinalysis are valuable tools in the right context, they must never, ever supersede the clinical picture of a sudden onset acute scrotum with an absent cremasteric reflex.
I think the takeaway for our listeners is that high-stakes time pressure fundamentally alters clinical decision-making. You have to balance the risk of a negative surgery against the tragedy of a misdiagnosis.
And in this specific pathology, the cost of a miss is permanent loss. That is why we run the red lights.
A complex issue with a very simple deadline.
That brings us to the end of this debate. Thank you for listening to The Debate.
Until next time.